What about after one decides to provide initial treatment? How does one decide how long to continue, whether to become even more aggressive? I've heard the PSA levels are used by some, that if they go up, one needs to get more aggressive. That seems to be somewhat controversial. What do you use, or what do you think should be used to determine whether a patient's initial therapy is enough to sit back and watch rather than get more aggressive right away?
Well, I think that there are now both two trials. One was an American trial and another European trial, an RTC trial, looking at the role of potentially giving adjuvant radiation immediately after prostatectomy, or a short time after prostatectomy, for men with high-risk features, meaning either large tumors or a seminal vesicle invasion. And there is most definitely a decrease in local recurrence that seems to be associated with giving clinically significant decrease in local recurrence in men who receive salvage radiation, or adjuvant radiation after definitive therapy. And what these two trials have suggested is that these high-risk features are an important indicator of the potential for relapse. And so although neither of these trials have shown a definitive survival benefit yet, in terms of both PSA recurrence and local recurrence, we are starting to get answers that giving adjuvant radiation might make a difference. A related question to that is what happens, alluding to this, what happens if somebody's PSA starts to go up after they've received their prostatectomy? Is hormonal therapy the right answer, or should they move on to something else, for instance, radiation? And here too, there's now, I would say, a fairly large body of patient data suggesting that giving salvage radiation therapy can in fact provide a potentially cure even for patients with high-risk features, meaning even for those patients with the short PSA doubling times or high Gleason scores. Initiating salvage radiation and not waiting until patient's PSA goes up to 2 or 3, but initiating salvage radiation when PSAs are very low, the lower, at 0.5 or less. These patients, there is even a 30% cure rate, even for men with very high-risk features. The numbers go up to around 70% for men with relatively indolent disease.
As is my want here to get people to think about possibly new insights, has anybody thought about the role of continued or discontinued sexual activity in prognosis in prostate cancer? The reason I ask, obviously, is that it's the metastases that kill people, and I'm kind of wondering whether the sexual activity itself may, in those who continue to have sexual activity, might in fact cause shedding of prostate tumor cells that might otherwise have been happy to continue to be adhesive and remain localized. And as part of that, the business of androgen inhibitory substances, could some of their benefit, when they're beneficial, be in fact that they decrease, possibly prevent libidinous activity?
It's an interesting question, right? Because we do know that just because somebody has prostate cancer cells that are circulating, right? So for instance, somebody has elevated PSA after a prostatectomy, that means there are prostate cancer cells.
Can you assess prostate cancer cells in blood?
You can't. There are now mechanisms for looking at circulating tumor cells.
Okay.
The number does go up as patients progress, so that in the metastatic setting, there are prostate cancer is one of the tumor types where we tend to see even more circulating tumor cells than in other diseases, and that's again technology that has developed in the last few years. But even for men who just simply have PSA relapse per se doesn't necessarily predict for mortality. There are certain features within the men who have PSA relapse. So there are some men who have PSA relapse, and their PSA goes up very slowly. And we know that those men with data from Johns Hopkins suggesting that men with PSA doubling times of more than 15 months have a relatively low risk of dying of their prostate cancer. Conversely, men with a PSA doubling time that's less than 3 months will likely die of prostate cancer within the next 5 years. Now, to what extent does sexual activity contribute to that? I think it's really much more a function, to be honest with you, of the biology of the tumor itself. Because we know that even when there are cells that are still viable, that there are many men who presumably are living normal sexual lives and still are not going to die of prostate cancer. And unfortunately, some tumors with very aggressive features and rapid doubling times. And ultimately, I think that's a function of what genes are driving the tumor to grow.
I agree. Mark, thank you very much. I actually look forward to seeing some circulating prostate cell counts in patients before and after sexual activity. I think it could be terribly interesting, recognizing what you had said, that every prostate cell that circulates doesn't necessarily cause a micrometastasis, but there may well be a correlation. Thank you for participating, and thank you for your work on Hem/Onc Today.
Appreciate it. Thank you.
Thank you for watching this video from Hem/Onc Today. Keep up with all our new videos by visiting the Hem/Onc Today YouTube channel, or go to our website at hemonctoday.com.